Hi, everyone. Welcome. Welcome. As you're logging on, we're real excited today. As always, we always have our action-packed Navigator training focus series. Today's subject is methamphetamine use and update. You guys have been asking and requesting for this subject matter, so we're bringing it to you with some experts here, and we're just going to wait a few more minutes just so people can log on. People are still logging on, and if you can do us a huge favor, can you please tell us where you're from, what city as well? Because sometimes your hospitals, we don't know what city that is, unfortunately. And how long you've been a navigator. We always love to hear if we have new people, if we have our wonderful existing, I don't want to say senior, so I'll say existing navigators, our experienced navigators. So please type it in the chat. We'll get started in another minute or two. Hello, Vanessa from Quincy, California, and Katie from UC Irvine. This is one. Culver City is in the house, so this is wonderful. We have everybody from all over California, Southern California. I see Rosalind from Whittier. I see Sharp Coronado. Welcome. So many familiar names and faces from our in-person. So I'm glad you're here. And there's Marin County in the house as well. So we're going to get started. We have some great speakers today, and so let's get started. As usual, we share all of our slide decks, and you will get a copy after our presentation, and it's all available through Creative Commons. That's who it's from. Our objective today is to understand the harms of methamphetamine, of course, verbalize understanding, right? Understanding of treatment options, understand harm reduction strategies for people who are using meth. So again, we have a lot to cover. I always like to review while people are signing on. If you don't know it, you guys know this stuff. I'm just repeating. California Bridge Model. We are revolutioning the system of care, and you guys are doing it, not we. You guys are out there on the front line, and we are here to always help and support you. As you know, we have 3 focuses: low barrier treatment. That's what your clinical champions and docs in the ED are helping with our patients by administering buprenorphine or any evidence-based treatment program, as well as your last 2 focuses are connection to care and community and a culture of harm reduction. So we know you're out there doing that, giving referrals for anybody who uses substance use, has substance use disorder, and as well as changing the culture in your hospital, which can be a very huge challenge, as we have heard from most of our newer navigators. But we're here to help. So we're really excited to have you today. And I'm just going to get started because you may not know, I didn't know Daniela, but now I feel like we're old friends, Daniela. Daniela Waki is a navigator at Highland. She has been working as a harm reductionist in the San Francisco Bay Area for 25 years. She serves as a consultant for stimulant use for the FDA and United Nations Office of Drugs and Crime. So she has extensive history, and she is willing to share that with us. And we're so excited to have her. She's going to start off and just tell us about methamphetamine. Where did it come from, Daniela?
Wow, where did it come from, Sherry? Well, first of all, I wanted to thank everyone for your interest in this topic. It's certainly an issue that we need to talk about very openly as harm reductionists, as people who are doing this kind of work. Estimated that 2 million people in the United States use methamphetamine on a regular basis. And we're seeing some associated issues with new populations of people, new communities starting to use methamphetamine. And we're seeing a lot of trends that we'll talk about a little bit later about people of color, people who are disenfranchised being disproportionately affected by some of the chronic and acute problems associated with meth. But I want to talk a little bit about meth because it's sometimes it's a mystery, right? Or a lot of us have this impression of meth as something that people are making in their backyards. So let me tell you a little bit about what meth is today. So a brief history of meth: it was invented in the late 1800s in Japan, and it sort of became widely known as a substance used by people in war in World War II to continue to have energy in combat. And the first time that it really started to poke its head out recreationally was in the 60s and 70s when biker gangs started making crank, which is actually, it was methamphetamine, but it's a racemic form of meth. And if we have time later, we'll talk a little bit about what that means. It's a less potent form of methamphetamine than pure dextromethamphetamine. So again, we'll come back to that. So what happened in really the 80s and 90s is that people figured out that through smurfing pseudoephedrine, that pretty easily people could make small amounts of meth or large, if because it was unrestricted at the time, pseudoephedrine. We all have heard about that, about the toxicity and the waste, and so that's the picture that people like these still have of meth. But this is what happened. It was quite interesting to me. In 2005, Congress passed the Combat Methamphetamine Act, which ended up restricting pseudoephedrine sales. So that's Sudafed, the nasal decongestant. It is available in California, still at pharmacies, but you have to ask for it. You have to slide your ID because you're limited, I think, to 2 grams a month. That's because, again, people were able to convert it. But when Congress put the kibosh on that, it really killed domestic production of meth. And in that lull, the Mexican cartels, who are so good at tuning into the drug needs of the people of the United States, decided to get into the game, particularly because the drug war was shutting down their supply routes for cocaine and for heroin. They thought, why don't we just make our own product? So Bing, they started manufacturing basically in super labs, is what we call them now. They are, without getting too much into the nitty gritty, which I love to do, so hit me up if you want to talk about it, but they're using a precursor called P2P, and it was made famous by Breaking Bad. They never addressed this particular issue, but it creates a very pure form of meth that again is racemic. It's levo and dextro, but what they're doing now is they're actually stereo enriching the meth, meaning that they're removing the levo part and leaving just the dextromethamphetamine. And that's why meth comes out in these beautiful crystals, is because it actually is this very pure and chirally all oriented in the same direction, and it kind of forms what we think about, the classic look of like a shard. So what we're seeing is that that essentially is all the meth in the United States that is for sale at street level is being produced by Mexican cartels. In California, it's the Sinaloa cartel. They come up the 5, usually bringing meth in the back of tractor trailers by United States citizens. And then it is sort of dispersed throughout California. And I just wanted to let you guys know, that it's out there. It's extremely pure. Breaking Bad, they always said they were like 97, 98. We're at about 99% purity. And again, we're at all dextromethamphetamine, which means that it is the most potent form of methamphetamine molecularly. So do you want to start talking, Josh? I feel like I've been talking for a while, but we can get into or I can talk about how meth affects people. What do you guys think?
Yeah, why don't you go ahead and talk about before we bring Josh out, Daniela, how does meth affect people? We want to hear, we want to know truthfully.
Okay, sure. So meth releases a lot of different neurotransmitters at one time, particularly dopamine, norepinephrine, and a bit of serotonin. So there's a big norepinephrine, and correct me if I'm wrong, I think actually becomes adrenaline, and it activates, it's very awakening. it creates quite a bit of energy, and in folks who are not extremely tolerant, it creates a real sense of euphoria, of well-being, of confidence. It's a very compelling feeling that a lot of people use so actually the United States is second in meth use in the world to Southeast Asia. But in Southeast Asia, it's usually taken in pill form, and people use it to work several jobs at the same time or to stay up and to continue to work. So meth is used mainly around the world for its utility and helping people work longer and stronger. In the United States, we know that, again, there is also the work issue, but we know that there's a lot of people who are marginally housed, particularly in California, who use meth to stay awake, to protect their belongings, to protect themselves, because if you pass out like in a tent, you're kind of in a vulnerable state. And so there's a real use of it for self-protection as well. We can talk a little later about some of the acute and chronic effects of meth, because unfortunately that beautiful, pristine euphoria does not stay for long for people, but it's a really compelling feeling that people chase. And problems tend to ensue from that kind of chronic dosing.
Thank you so much, Daniela, for giving us the background, so much that we don't know, right? So now I'm going to bring in our favorite PA from Highland, Josh Leftig. He is the co-founder here at California Bridge. So you have a VIP in the house. He's the director of harm reduction. And again, he's the physician assistant at Highland Hospital. And welcome, Josh, and thank you for bringing your Navigator. And I know you guys are going to go through the slide deck together. And I appreciate both of you being here.
Thank you. I just noticed that they started chainsaws right next door.
Oh,
so
no.
how's my
we can't hear it.
You can't hear it. Okay.
Okay, and
good.
then I'm going to ask the audience, if you do have questions, you could type it in the chat. We're going to wait till the end because we want to make sure that we have enough time that they get through the content. We have a lot of content to present. So if you have a question, put it in the chat. We will address it at the end. If our mentors or Charles Hawthorne can address it, they will address it in the chat as well. So again, hold off on our questions. Josh, the floor is yours.
Great. Well, thank you so much. And Daniela, thank you for that background. It's always, I learned something every time. And this time I learned more about the chirality and the way the crystals form and why you get those amazing crystals. And then what smurfing is. That's not a term that I was actually looking it up while you were typing. So that is the slang term for converting Sudafed into methamphetamine. Got it. Okay, thank you so much. So, so what do we know about meth? So by 2021, the number of methamphetamine involved deaths increased to over 52,000, with 61% of the methamphetamine involved deaths in 2021 also involving heroin or fentanyl. So how do you make sense of these numbers? So first of all, the number of deaths in 99 was under 1,000. So we've had like an 86-fold increase in the number of meth involved deaths. So this is a new phenomenon. This is not something that emergency medicine has been familiar with, this level of fatality rate in our community. And then the other thing is this association with opioids. So there's a correlation with opioids and fentanyl. So it's not just a pure, while there's a whole set of mortalities and health effects and harms that can come from meth alone. There's also there's this co-occurring opioid use and meth use and co-ingestion that is happening that's also driving fatality rates and leading to unintended overdoses that we're going to try and get our heads around today in this talk. And there are also another way we've been thinking about this is the fourth wave. So we have the first wave was prescribed opioids, and then we had the this is the waves of over time since 2000, late 90s, 2000, we had the first wave of prescribed opioids. Then we hit that transition to heroin and street pills. And then that transition to fentanyl. And then we've got our fourth wave, which is fentanyl, which is continuing to spike, but we've got this other spike underneath, which is methamphetamine, stimulant, and opioid associated overdoses. Next slide, please. So meth signs and symptoms. So this is as Daniela mentioned, the euphoria and the focus and the vigilance and the intense reward. This hijacks your dopaminergic reward system in a very powerful way. And it can be, beyond the euphoria, that's where the euphoria and the reward piece comes in. But the focus and vigilance is also a huge element of this for people who are working 2 or 3 jobs, trying to keep all these pieces together, trying to get from A to B in our, as they're struggling financially with housing, all the social determinants of health. And then if they're homeless, and staying vigilant, staying awake, self-defense. And then the harms that can come from acute use are also the over-amping. So beyond just the medical harms, the actual the hypothermia, hypertension, and agitation. So those can actually be the sort of medical manifestations, but they can also lead to traumatic manifestations. So if you are climbing up a building and in an unsafe situation and you fall off a roof, or you're in traffic, or you're driving a vehicle, or all these things that can, you can lead to trauma and behavioral issues. You can be incarcerated. You can have lots of adverse outcomes related to the agitation and hallucinations and paranoia. So you can be you can attack something, you can be violent, you could be unaware of your circumstances and act in a way that is not safe for yourself and others. The other thing is formication and skin picking. So this is formication is a medical term for a sense of having sort of skin, something crawling on your skin, like you're having a perception of your skin crawling. Daniela, do you have anything you'd like to add to the acute use phase here?
I just wanted to sort of stress the cardiovascular effects of acute meth use. One of the major effects of meth is that it's a vasoconstrictor, meaning it constricts blood vessels in the body. So because it squeezes the blood into a smaller space, that drives up blood pressure tremendously. So one of the unfortunate outcomes of having this acute spike in blood pressure can be like brain hemorrhage. It can be cardiac, like an MI, what do you call it, a heart attack, because again, it also is narrowing the vessels within the heart. And so the heart is not getting enough blood and enough oxygenation to keep beating. And then we also get into the chronic use of when the heart is beating constantly against high blood pressure, the heart starts to remodel. So the cardiovascular effects cannot be like understated, especially for folks who are older and transitioning to meth use for the first time, a lot from other drugs. And that's what we're seeing, I think, a lot in the hospitals. We're seeing those secondary effects, things like that I mentioned.
100%. Yeah. And then the other piece is dissection. So you can have, basically your aorta coming out of your heart, the linings can separate, and you can, it's often fatal. But yeah, tremendous cardiovascular effect. The chronic use, that's where you get to kidney and liver problems. And as Daniela mentioned, that the congestive heart failure you can get, which is we commonly see after ongoing meth use. And then persistent psychosis. So you have like the acute paranoia, but then you can also be left with a persistent psychosis even after the meth has completely left your system. So you've metabolized everything, and you have a residual psychosis from chronic meth use. And withdrawal syndromes. So the withdrawal syndromes typically in the acute phase, that is going to be what we call meth washout. So you're just completely catecholamine depleted. You're very hard to rouse. You're just sleeping deeply. And that's a time, like in the ED, we often have people sort of spending the night. So they're sleeping off there, and we're often hydrating them IV and then letting them leave in the morning. I would like to mention the tooth decay. So Daniela, you have something to say about the tooth decay associated with methamphetamine.
So meth mouth, we have actually found out, is not a result of methamphetamine ingestion itself, but it rather has to do with some of the psychosocial and quality of life issues that people who use meth experience. So it is related, I think, somewhat to dry mouth, which meth can induce, but it really has to do with ingestion of like lots of sodas, lots of just poor quality food, and then a lack of oral hygiene that can come when people are kind of on a run and not thinking about it. So it's always good to like see what's underneath maybe some of these phenomena that we're seeing, because it actually is not directly related to the drug itself.
Great point. Next slide, please. So routes of administration, so swallowing, these are rough guidelines. Swallowing, you're going to get a peak concentration that's seen within 2 to 4 hours. Snorting, smoking, or injecting, you'll have a much rapider onset of peak concentration that'll happen within minutes. And smoking, injecting, or inserting rectally, which is also known as boofing, allows the drug to reach the brain faster, which causes an immediate and intense rush. The effects of meth can last for many hours. So whereas crack cocaine would be short acting, this is much longer acting, and it can take up to 4 days for the drug to completely leave the body. So Daniela, would you mind mentioning, so I just want to talking about some of the ways that smoking, the route of onset, when you smoked, is a way that people can pace themselves, and can you go into that a little bit?
Yeah, sure. I thought we had like edited the slide a little bit, but I'm glad that we to the idea of how these different routes of administration really affect the way that people feel. Like an all-at-once dose that hits all at once, like an IV route, boofing, like snorting to some degree, swallowing, is going to feel different than smoking. So smoking, you may end up using the same amount, like in terms of milligrams of meth in a period of time, but instead of getting it all at once, you're sort of titrating it a little bit. You're getting like these little bumps of drug, which, you know, that actually makes smoking like really addictive, because you're just getting like these little like, and you just want to keep chasing that feeling, because it feels really good. But for folks who are concerned about overamping, and want to like kind of dial it in a little bit better, smoking can be really helpful. I wanted to mention, right, if I could, Josh, about the difference between the psychological high of meth and the physiological high. So it's important to know this. When somebody takes meth, let's say smoking it, or whatever route, the once it's in the bloodstream, the peak psychological effects, the high, peaks at approximately 15 minutes. However, peak plasma levels of meth continue to rise over a 2 to 4 hour period. So the cardiovascular effects of meth and the physiological effects of meth actually peak at 2 to 4 hours. So there's this mismatch of the psychological high and the physiological high that can be dangerous, right? Because people are like, I'm not high anymore, I need to use more. Meanwhile, they're getting more and more hypertensive. It's accumulating. So that's, something to be watching out for.
Absolutely. Yeah. So that's a great thing from a navigator perspective. That's how you can counsel your patients, is to caution them that they can run into dose stacking, where you're actually piling dose upon dose, and you're not perceiving that, because your psychological, as Daniela said, your psychological high is being maintained or even diminishing, but your bloodstream plasma levels are rising. So you're having your blood pressure is just like going through the roof, and you're not perceiving any of that, and you're at this great medical risk. Next slide, please. So meth and fentanyl. So this is so we've decided to sort of break this into a couple categories. There's a lot of confusion around this, and it's such an important topic, because so much of the current overdose crisis is driven by these combinations of these two substances. So as we know, everything's headed towards methamphetamine because of, Danielle, as you pointed out, the manufacturing process has made it incredibly potent. There's a well-established pipeline and purity, and so we're moving away from other forms of stimulants and moving deeply into the meth world. And the same exact thing's happening with fentanyl. So with opioids, we're going to we're not growing poppies in fields and doing all that business. We're just going straight to the molecules that are being refined, very high purity, easy to transport. So this is kind of where we're landing here, and then probably even more powerful substances as we move into the future. So what's happening here? So we have intentional. We're going to break this into intentional co-use and unintentional co-use. So intentional co-use has some benefits and some risks. So and actually, Daniela, I'm gonna ask you. So what would you describe a common pattern of intentional co-use might be?
It depends on the route of administration. So the question is like, why are so many people co-using? And the reason is there's this synergy between the two drugs that feels particularly good. Like it's more than the sum of its parts. It takes the edge off. It takes kind of the edge off of meth, and then it helps. Then meth helps people to not be so sleepy and nod from the fentanyl. So it makes people more functional. And there's also this idea that meth is protective against fentanyl overdose, which is, a very controversial point and generally untrue. I think that's the message that we want to give people. Like, meth is not an antidote to opiate overdose. But yeah, there's a reason that people are using it, and the way that people are using it is, it depends on the route of administration. So people who are shooting are usually shooting together, the fentanyl and the meth. And when people are smoking, so here in San Francisco, I'm going to refer a lot to San Francisco because that's the area that I know well. We have this tremendous smoking culture. Like, people are all over the Tenderloin with these like dab rigs and these glass contraptions, and people smoke here. When people smoke, they generally they don't smoke both at once, because if you fentanyl, unlike meth, is not pure. It's about 15 to 20% pure in California, from what we know from drug checking. And everything else in the fentanyl is like filler. It's usually mannitol or some other sort of soluble kind of sugar, something kind of inert. But when you light it up like in a bubble or in like a pipe, then that stuff burns. And so people generally don't want to put meth, which vaporizes completely, in with something that's burning, because it just makes it yucky. It makes everything burn. So when people are smoking, they generally stagger it a little differently, which may also be somewhat protective. But I could go down the rabbit hole with fentanyl as well, and the pros and cons of smoking versus other routes, but we'll stick with the meth for right now. But do you want me to talk a little bit about, why don't you go into unintentional co-use, and I can drop my little nugget whenever you want.
Yeah. So there's, there is some, there to some extent, there is a protective, like if you're, it does, like as Daniel said, it takes sort of the worst effects. They do complement each other in a way that is to some degree beneficial. Like if you're using one, and you're over amping and you're running in traffic, but if you take some fentanyl and now you're having a more even high, like that is a net benefit for someone who's in active use. And on the other end, again, if you're using fentanyl and you're unconscious and you're in the road or whatever, or you just can't protect your belongings or yourself, and the meth allows you to actually be just functional. So there is this like mixing and matching to find kind of the perfect balance that's occurring in the community. And that we're going to put in intentional co-use. So unintentional co-use. So this is where someone believes they are using one substance and they're actually using a combination of substances. And Daniela, can you go into what are some common scenarios where that's happening? Because I think this is where the researchers who are sitting in an office and not on the street are getting a different idea, and sort of the lay public has a different idea of this unintentional co-use than is actually happening. So Daniela, if you could kind of break it down for us and give us sort of the street view of what is actually happening with this unintentional co-use. Yeah,
so I'm gonna say something a little provocative right now, but let's do it, right? Let's get real. So a little trivia question. So unfortunately, this is not backed up by, it has not been published yet, right? It's hot off the press, but pre-press, we should say. My dear friend runs the drug checking spectrometer in San Francisco. There are a few of them running in California. If people email me afterward, I'm happy to try to link people in your area to drug checking. It's a little bit on the DL right now because it's federally, it's like an iffy legal situation. And so we just want to protect the services and kind of keep it out of the hands of law enforcement if we can. But so since June of 2022, there have been 140 samples of meth presented for FDIR spectrometry, and then sent for GCMS, meaning that it was then sent to a lab for analysis, like down to the last molecule, like what is in it. So out of 140 samples of meth, how many of those contain fentanyl? This is primarily meth purchased on the streets of the Tenderloin in San Francisco. Got a number in your mind? Okay, the answer is 2. And both of those samples were meth that were kept in a container that had fentanyl in it beforehand. And that was known to the person who was using it. When they ran it on GCMS, the ratios were about 10,000 parts meth to 1 part fentanyl. So am I saying that this is like true everywhere, that the meth is devoid of fentanyl? You know, I'm not, but it's very interesting, right? Like, I don't know what we can extrapolate from that. But what I can, at least in our local scenario, talk about is what is really killing people here when they're co-using. And one thing that, having worked a long time in the Tenderloin and experienced some of this myself personally, is this white powder confusion. So fentanyl often comes as a white powder or a white rock, which looks very similar to cocaine, to ketamine, to crack. And there's often, in my experience, every time that I've seen it, there has been an overt substitution issue where somebody thought that they were ingesting one thing, but it was actually another. And that is very problematic. And that's why actually rainbow fentanyl, remember like the hysteria over rainbow fentanyl being marketed to kids, that's actually a branding thing to help people get the same potency from the same supplier. And it also helps differentiate these white powders because people accidentally smoke the wrong thing or ingest the wrong thing all the time, especially when it's dark. And, you know, sometimes the dealers themselves are a little confused and they're pulling, you know, they pulling it out from wherever. The other idea in San Francisco, at least, is, again, I mentioned the smoking culture. We have glass all over the place. People are borrowing each other's glass a lot. And a residue that is left in those pipes. And so people will often unintentionally ingest that way. So that, in my experience, so when stuff does come up, like there are samples of meth that sometimes come up with fent. And what we found in almost all of those cases, and that this is again outside this area, that what was at fault primarily was like sloppy work by the dealer, like not cleaning off the scale before weighing out different things, or just again, like this white powder, like scooping a little bit here off the table. And so it's been like accidental, because I can go down the road with this, but there is no reason for a meth dealer to put fentanyl in the meth. Meth is more addictive than fentanyl. It's more dopaminergic. It's really cheap. There's no reason to pay more money to put something in your drug. People don't want to buy a drug that gives them unexpected effects. And lastly, you don't want to kill your customers. It's a really bad business model. And now with this drug-induced homicide stuff and fentanyl stepping up, you know, with DAs all over the country prosecuting people for murder for selling fentanyl, and that resulted in overdose death, like people don't want to intentionally put fentanyl in other things. So I know that's like the most provocative thing I'm going to say today, probably, but thank you for considering it.
Thank you, Daniela. That's great. You know, and there's also, especially when you go way upstream to the cartel level, at the cartel level, as you pointed out, they're making, for the methamphetamine, this is coming in crystalline form. This is an incredibly pure product that is not going to be mixed with fentanyl at that step. So it really is down, like the further you get from that step, one, because the physical methamphetamine crystal can degrade into a powder, the more times it's handled and passed from person to person to person, and the more it's in a powder form instead of a crystal form, the more easy it is to get mixed in with other powders or be left on a scale and mixed together accidentally. But most of it, you know, so that's kind of the nature of the unintentional co-ingestion. And probably a lot of this, as you said, is someone grabbing the wrong powder, grabbing the wrong pipe, sharing a pipe, and they don't know what's in that pipe, or the pipe was just used with something else. And that's where the cross-contamination is happening, rather than a nefarious dealer or cartel person. Not to say that these people are all fantastic people, but I'm not saying that that's kind of the narrative that's being passed to the lay public and the press, and that they're running with, that this is that this is just an evil empire that's doing this particular thing to try and hook people into it and intentionally murder people, like is really what's being said. So I think, thank you for giving that clarity in this important topic, because this is a very stigmatized population, and these narratives that are false and further stigmatizing are not helpful at all, and they're not going to help us help our patients. So thank you. So we're going to go into a little bit of how this co-ingestion and co-intoxication and co-withdrawal and how that all can kind of fit together in some real scenarios and can confound things. So when you have someone in opioid withdrawal, and I want to back up one step too, is that whenever you have any, one thing we didn't mention that is really important, an important element, is that co-use. So people usually identify with one substance, and we as clinicians and navigators tend to identify with them with one substance. But the vast majority of people at this point in time are using multiple substances, and they're usually using fentanyl and meth. If they're using one, they're usually using the other. So it's really important to have heightened awareness to really kind of dig into that and really understand that. And this is one example of why that's so important, is that when someone's in opioid withdrawal, but they also have, because often fentanyl you can slip into withdrawal quicker and start to have withdrawal symptoms while the meth that you took around the same time is still active in your system. And so you are having the physiologic, it will confound your COWS score. So you're getting ready to give buprenorphine because you're like, wow, their cow is like 13. But the COWS is only for the symptoms, the signs and symptoms that are attributable directly to opioid withdrawal, not to the co-occurring meth intoxication, which looks identical. So you've got dilated pupils, you've got the tachycardia, you've got the elevated blood pressure, you've got all the symptoms of withdrawal, and meth intoxication are the same, basically the same toxidrome. I think the only thing that you could, sort of say is maybe yawning would be more of an opioid withdrawal specific thing, but the rest, and maybe some of the nasal congestion and the tearing, but most of the sort of the COWS score is going to be confounded by meth intoxication. So it's really important to get a good history and identify, hey, when did you actually last use meth, so that I can tease out what's going on in this sort of complicated situation. And then we're going to probably wait a little longer before starting buprenorphine, so we don't precipitate withdrawal if there's meth on board, as we say, where they're having that syndrome of meth intoxication. So that's what we wanted to hit with that. Next slide, please. Treatment modalities. So there's, I think one thing to put this in context is that for opioid use disorder, we have buprenorphine, and buprenorphine is just an amazing molecule. It does a great job of stabilization and protection and craving protection and all these amazing things. And its treatment, the number needed to treat is 2. So it has a very high impact. These list of treatment modalities that I'm putting here are lower impact for methamphetamine. We don't have a buprenorphine equivalent that has that same degree of impact. So we're working with what we have. And these medications are, right from the ED. So I will often prescribe mirtazapine plus minus olanzapine. Trade name is Zyprexa. Common brand name is Zyprexa, which is more familiar to people. And so mirtazapine is an antidepressant that can help with the sleep disturbances that are so common. A lot of sort of coming down, and people are trying to cut down on their methamphetamine use, cut down or quit, are left with this horrible sleep disturbance and also dysphoria. So their mood is, they're completely, their dopamine stores have been depleted and their mood is incredibly low. And so the antidepressant effect and the sleep restorative effects of the mirtazapine can be beneficial. So usually just starting 30 milligrams a day. And then if they're having any kind of any psychotic features, or, I will screen people, hey, are you having, do you ever get any racing thoughts or they're just paranoid, feeling kind of like people are watching you or following you, then I would add in some offer olanzapine. Or if you ever been on any medications that's helped with that, and then I would offer this medication to help with this antipsychotic features. Then you have naltrexone. And so that's basically the ER package, typically, just the top line. That's it. And then for follow-up, these are the rest of the intervention, some other options that people will have, which would be naltrexone IM, which is going to help blunt some of the reward. The naltrexone, so this is the brand name most commonly is Vivitrol, and that is used, we use that for alcohol use disorder, and it blunts the reward pathway so that to kind of help break that cycle of use and reward. And bupropion, another difficult to pronounce medication, which will help restore some of the dopamine tone and serotonin tone in your system. So it's basically, just kind of getting to the neurochemistry and rebalancing, doing a little bit of what buprenorphine is doing, sort of restoring the adrenergic tone in your system and rebalancing things. And so that's basically the current. That's most of the current package that we work with. There are other modalities that I won't go into that are beyond the scope of what we're doing here in terms of medications. And then you do non-medical interventions such as contingency management and cognitive behavioral therapy. And then we're getting into even more research level interventions where you have prodrugs such as lisdexamfetamine, which converts into a amphetamine, and TMS, which is transcranial magnetic stimulation. These are other innovative areas of intervention for substance use disorder, stimulant use disorder. Daniela, do you have anything you'd like to comment on this particular package of interventions?
Yeah, just when I think about this package, I look at the mirtazapine and the olanzapine. Is that Zyprexa? It's for the sort of the acute management. Thank you. It's for the acute management of sort of withdrawal symptoms and the washout and the acute intoxication, to get people to chill out, to sleep, to not be so activated and paranoid or hallucinating. And then I think about more like Wellbutrin, which is bupropion, being more for the aftermath, right? Like after you stop using a powerful stimulant, you feel pretty tired for a while. And that is a huge trigger to using again, because you feel like you cannot function or stay awake for more than a couple of hours for a while. And Wellbutrin is very activating. It sort of hits the spot and can really help people. So it's not about, we're not doing like has been mentioned with Suboxone, with this magic bullet, but we're rather looking at the symptoms and symptom management and the reasons why people use in the first place, like what physical sensations or what are they experiencing that drives them to use it, and we address that more often. And I just wanted to mention, like Suboxone, sort of in that line of thinking or thinking of safe supply, there are some providers who are prescribing amphetamines to people who use meth as a hopefully to substitute for the safer and more controlled pharmaceutical. And the reason that lisdexamfetamine, which is Vyvanse, is super cool is like you can't break the time release on it. It's not like a pill, like, OxyContin was like a pill that you could like chew on it and like break it up, because the actual medium of the pill would slowly disintegrate in the GI tract. So how Vyvanse works is that it is an inert molecule until it passes through the lining of the stomach, in which the lysine is cleaved off by the red blood cells in your bloodstream, and there's just no way to speed that up. So it's kind of a neat way of putting the brakes on someone's potential misuse of taking.
Love it. Love that there's people innovating in this space. All right, we do need to keep our pace up.
I was just going to say that, Josh.
Yeah, Sherry. I saw Sherry appear. I'm like, Mom's here. We have to keep it going. All right, next slide, please.
I know there's so much, and we have so many questions. So
so we want to be able to hit some questions. Okay, so supporting patients, we talk about washout, just help people, let people sleep and keep them hydrated. Intoxication, we want to you know, when people come in, they can be very agitated, they can be confused, they cannot be themselves, they can be paranoid, hallucinating, and safety's first. You want to maintain your own physical safety, and use your de-escalation skills, talk people down, reassure them. You know, there's, you know, rely on the rest of the, you know, this is not all new. This is a team sport. In emergency medicine, ERs are usually very good at helping manage agitated patients, and both chemically with medications, with Geodon, Versed, restraints if needed, whatever needs to be done to keep the patient and the staff safe, keep yourself safe. And then, you know, navigators are natural chaos sponges. So this is where you can really shine in helping, you know, minimize the amount of restraints and chemicals that are needed to use. You can use verbal de-escalation. Next slide, please. We'll just run through a case really quickly. This is 42-year-old male. He's been using meth for 5 years. He uses fentanyl 2 to 3 times a week when coming down. He's currently agitated, paranoid, thinks he is being watched and followed. And let's just add that he tried to take a swing at one of the medics when he was being brought in and is now in the room. Next slide. So what are we going to do? We're going to de-escalate, like we talked about, restraints, medications if needed. And then once he's able to, you know, be himself, we're going to offer mirtazapine plus minus olanzapine. This, he has had some psychotic features. So this is probably, when you talk to him, it turns out he has been on Zyprexa in the past. So we're going to reinitiate that. We can give him a dose right now in the ED as well. We can also give him a dose of mirtazapine right here in the ED. So these two medications are going to be his sort of ER package, and along with buprenorphine. So he's using 3 times a week, he's using fentanyl. So that is, you know, they're having a synergistic effect. So we're going to start him on bup, and we can, let's see, we'll do a COW score. Now we also know we're going to think about the fact that he's acutely intoxicated with methamphetamine. So that's going to throw off his COW score. So we're going to make sure that if he, you know, if it's been a couple days since he used fentanyl, then great, we can just start him on bup right now. If he just used fentanyl along with that meth, then we're going to probably wait. We'll make sure he has Narcan in hand. We're going to talk to him about how he's using and, you know, being safe, you know, assuming if he's not immediately ready to quit, or if we know even if he's prepared to quit now, he's likely to relapse. We want to make sure that he knows about mixing up powders and rocks and pipes and that confusion that can happen and how that is such an overdose risk. And we're going to assess all the, you know, like, is he homeless? What are some other things that we need to address? Talk to social work as needed and get him, make sure that he's got a safe place to stay. And we're going to give him fentanyl test strips to make sure that he's able to test if he gets a powder that he thinks is just meth powder, that he can test to make sure that there's not fentanyl in that he's not co-ingesting 2 substances that he's not aware of. Next slide. Harm reduction. So let's talk a little more about harm reduction. Next slide. So avoiding over amping. So like Daniela mentioned, you know, people who can you maybe switch to smoking, where they're just taking little hits and trying to pace themselves, but at the same time being aware that they can be at risk for dose stacking, where the physiologic effects can be ramping up over 2 hours, where they're having the psychological effect within a couple minutes. Drinking plenty of water, getting plenty of sleep, eating proper foods. These are the things that are preventing the tooth decay and the other hygiene issues that are associated with and the severe dehydration and the kidney issues. When you're dehydrated all the time, that is not beneficial for your kidneys. Not using alone, carrying naloxone, all our standard harm reduction stuff that we use a lot for opioids. Also, much of them apply to the stimulant world as well. Next slide. Fentanyl test strips, we have an important update. Next slide. So those of you have already been implementing, you've been seeing these. These are the widespread use strips in the US until now. And they have one big problem, is that when you use them with meth, they get false positives really commonly. You need to really dilute a lot. It becomes incredibly complicated because you're trying to do an extra dilution, and you're trying to do this maybe in the street with bottle caps, and it's a lot to ask. And the problem is that's one of the most important times when we need to test for fentanyl. If you're using fentanyl, you don't need to test for fentanyl. You know, you bought a rock that's candy colored pink because you bought it from that, you know, like that's not the time you're testing. You're testing when you're like, I'm using a stimulant, but it's maybe not in a perfect crystal. maybe it's in a little bit of a powder and I'm a little suspicious that maybe my dealer mixed it up, or I'm, so then you're going to test it. And so next slide, please. What we'd like you to do is we're all switching. In fact, to the state of California, all the syringe exchanges now can access these news strips as well. They're provided by Dance Safe, has done an amazing job making sure they have a great source in working with the manufacturer to develop this product. So they are they come in a white package now. They may or may not, we're going to talk about 2 ways you can source this. They may or may not have this particular labeling. This is the Dance Safe labeling. And they have no known false positives, and they have a much more precise testing procedure, which I'll show you on the next slide. So this is, you use these micro scoops, 10 milligram micro scoops, and use a standard bottle cap. And notably these test strips are different. See, they are yellow test strips, and that's the business end goes in the yellow with the fentanyl, and then you fold it with the little dotted end. And you do careful scoops, like it says. This is basically the visual infographic. It barely uses words at all. Very simple to use. 1 standard bottle cap off of soda that you can find anywhere. 5 micro scoops, and then you test it. Next slide. So now that we've created this lovely situation where there's 2 test strips in the universe, we want to make sure that you're aware of that and that you're counseling your patients appropriately. The ones that are in a green package and are blue test strips, those are going to be, we're phasing those out in general, but they still are out there. So those are the ones that you want to caution them about the false positives with methamphetamine. And make sure your communication with patients if you get a new type of test strips. And remember, a lot of fentanyl test strips in general, it's not a perfect strategy. You're not going to ever have everyone take every single thing that they ever consume if they're using like 5 times a day and test every drop of that. So it's all about the conversations and awareness, and not confusing rocks and pipes and powders, and being really safe about that, and not using alone. And all the universal precautions are really the most important piece. So it's the conversations more than the strips themselves that are also part of the entire harm reduction package. And we have partnered with Conejo Health, and Charles can help you. If you reach out to Charles Hawthorne, we can get you basically white labeled packages that are the Dance Safe strips, but they don't have the Dance Safe. The Dance Safe is amazing, but they're also a little bit, they're rave focused. So in a healthcare setting, that may not always be sort of corporate friendly, which we're in a corporate environment in healthcare in general. So they're just white labeled. They don't have any dance kind of stuff on there. And you can get a free sample, and Charles will connect you with how to get started with that. Takeaways: there are medications for stimulant use disorder. There's a lot of, that's another myth, that there's nothing that can be done for people who use meth. There are lots of things that can be done. And we have resources for clinicians and navigators. If you go to our resources page on our website, and please educate your patients to provide harm reduction strategies. Yeah.
Well,
I think we covered
a lot,
that.
and we did it in time. And these are the best practices that we always like to share. So I know we have a few questions, and I do want to go to that. And the first question I want to answer is, yes, you will get the slide deck after this this presentation. We will send a post-event email with the recording and the slide deck. So if you missed something, I know the people were asking for repeat on the physiological and psychological methamphetamine use, with the effects, but it will be recorded. And so we want to come to the question and answer. So Ephraim starts with I've been using 12 panel now, rapid fentanyl test strips. Don't know if I should be concerned at all.
Oh, you're using the old ones?
Yeah, if I could answer that. So I think the immunoassay strips are generally very similar, like the tox cups. If you're talking about like there's the 12 panel like dip one, and then there's the one on the cup. But those unfortunately also fall prey to the false positive problem. If you really want to get in the nitty gritty of this, and this is hard to do if you're like on the street, but you need to dilute it. And this is for MDMA as well. If you're testing MDMA and using the old strips, you need to dilute it to less than 2 milligrams per ml of water. So the way to approximately do that is to take one of those dance safe little scoops that measures out 10 milligrams and put it in a teaspoonful of water, which is 5 mLs. So that's kind of like an easier way to check it. Yeah.
Oh, it's a great tip. Yeah. And there's also, if you have the older, I would please do not dispose of the older strips. Those are still valuable. And they, I would do exactly what Daniela said. They were the main barriers. They require additional training and additional dilution. So you can still use them. You just have to you're going to take a little more time explaining them and using also our resources. We have, if you go on our website, it gives you detailed instructions on how to use the green BTNX, the older test strips with meth.
Okay. There's a question back to meth that is really important. Can you discuss the cardiac diseases caused from meth use? We receive this question a lot from our navigators. So can you please address that?
There's basically when you're just kind of going from the heart itself. So when you get chronic remodeling, so we call it congestive heart failure is a common effect of chronic use. You can have so that's sort of ongoing, but you can also have acute use. So if you have done some dose stacking, or if you're more elderly, then you can have a heart attack, and you can have a stroke, or you can have a dissection. So anywhere sort of along the pathway of your cardiovascular system, all the way from your heart, all the way to the very end, little arterioles that are going into your brain, and your kidneys, basically anywhere in that cardiovascular system, you can have the toxic effects of methamphetamine. Daniela, would you like to add any?
Yeah, actually, maybe I'll talk about this right now. So, you don't have to be elderly to experience some of the cardiovascular side effects of meth. So my disclosure is that I actually had a methamphetamine overdose, and I had a brain hemorrhage. It was because I did not know what dose to take. And I consulted other people who were tolerant as to what dose to use, and I was quite naive. So this is one of my harm reduction take-home points too, that I try to talk with people about is trying to measure out how much they're using. And if you're new, you got to start slow and low, especially if you're using an all-in-one route of administration, because there's no going back, once it's in there. And the other thing I want to make, because we know like in San Francisco and stuff, there's a lot of communities. Somebody mentioned, I think in the chat, the PNP communities, like there's a lot of people who are having sex on meth. And oh shoot, I totally forgot my point. Oh no, it was a good one too. Remind me what I was saying. Okay, I'll come back. Oh wait, I totally forgot. I'm so nervous, but I'll come back. Thank you.
Okay. All right. Okay. No problem. No, hold that thought.
I got it. I got
Okay,
it back.
good.
I got it back. So booty bumping is a common way that people reduce harm from IV drug use. But let me tell you, you got to warn people, like if they booty bump, the rectal bioavailability of methamphetamine is nearly 100%. You got to dose it like you're going to shoot it, because it will hit you all at once, and it'll hit that entire amount. And it is so easy to overdose using that route of administration. So you just got to be super careful and weigh it out. And I do that particularly in communities where I know that people are, using it as part of sex. Thank you.
Okay. Wow. I think we've got a lot of stuff this session, and I really want to thank Danielle and Josh for everything they've done. I know there's more questions. If we didn't get to your questions, we will be going through the chat and we will email you. Okay. I really appreciate and thank you. I wanted to just go over our navigators, what you need to know. Remember, utilize your screening, find out what they are using, what's their drug of choice, was it intentional? Those are really strong words to use. Support medication treatment. reduce stigma and meet the patients where they're at. That's nothing new to you guys. And utilize these wonderful new harm reduction techniques, about sharing pipes. I mean, I learn from our sessions as well, and definitely making sure they have their own pipes to use, because that's where the fentanyl. So great eye-opening new things to consider. Provide your referrals and resources, and then always support recovery and offer hope to our patients. Okay, you're the key to getting them for harm reduction education, to getting them resources and services. Again, we thank you guys. Here is our QR code for any Navigator resources that you may need. We also have the California Bridge Academy that we do post our trainings and our webinars. So if you haven't logged on to that, there's so much on there already. You can contact our mentors anytime for any assistance. And here are Josh's email and my email if you have any more questions. We also are available on social media. We thank you. We met just at 12. Thank you so much, Danielle and Josh. This was amazing. So much information. Thank you guys. Have a great day.
Thank you.